ثلاثة.
طيب السلام عليكم، بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أنا دكتور شريف سمير. Today I will talk about ankle biomechanics. في البداية أحب أشكر مجموعة جراحة العظام بقيادة دكتور حسن بحاري ودكتور أحمد حسن وجميع الحضور، ونترحم على أخونا دكتور ساتي، وإن شاء الله ربنا يجعله مع الصديقين والشهداء وحسن أولئك رفيقا، ونحسبه عند الله إن شاء الله بإذن الله من الصديقين والشهداء. طيب الليلة حنحاول نتكلم عن ankle biomechanics which is a very difficult and complicated topic، وحقيقة هو واحد من التوبكس اللي هي it's very difficult to be understanding. بصورة عامة البايوميكانكس بالنسبة للريزيدنت ريجسترارز أو حتى بالنسبة لنا إحنا as consultant it's very complicated and it takes time to understand each joint biomechanics by itself. حقيقة البايوميكانكس it's a complicated process. It's not just like you need to know about any movement or just muscle action. It's a complicated process. Like in this picture, you can see this lady it's trying to dance a ballet. And this picture is proposed by some physiotherapist and orthopedic surgeon. His name is Newman. And here in this picture, he tried to explain to people that if you would like to do any kind of movement, there is a lot of mechanics working in the same time in different directions, against gravity, with gravity, sometimes in both directions. And you can see here, it's kind of beautiful harmony that makes people walk, dance, and do everything. طيب إذا تكلمنا بصورة بسيطة عن الأنكل biomechanics، طيب إحنا إذا قسمنا الجسم the body is divided into upper limb and lower limb and axial skeleton. For us, upper limb is using for function like writing, using your upper limb to reach anything, any subject, to eat, for fine movements, but lower limb usually it's mainly about walking. عشان كده احنا عندنا في الأورثوبيدكس بصورة عامة the most important is to understand the gait. This is a simple example that زمان لما تشتغل يجيك عيان multiple trauma patient and he have, let's say, upper limb fractures and lower limb fractures. Usually the most common question is which one is fixed first. Usually fix lower limb because movement, walking is more important than using upper limb because complication comes with immobility is more common. So in brief, if you can watch or see how is people walk, it's eight bases process. It starts with heel strike, flat foot and mid distance, and pre-swing, initial swing, terminal swing, and heel strike. For us, the most important is flat foot or foot flat and mid distance. Why? Because when you heel strike, you start to apply pressure through your ankle, foot, and this weight will be transmitted through these two joints to the ground. Also, in this phase, if you can see, the patient or the person usually stand by just one leg. So the whole weight is transmitted to the floor through these joints. And also here. So we need to understand what is the mechanism of doing these things. So ankle anatomy, usually it's bony and ligaments. We need to know about bone itself, and the ligaments, muscle around the bone, which help to maintain bone and structures in place. So all of us know that ankle joint is formed by tibia, fibula, and talus. And we have median and lateral ligaments of the joint, which is divided to superficial and deep. And for sport medicine specialists, usually they are taking care of these structures more than the bone structures, because this is the main check or main stabilizers of ankle joint. Also, we don't have to forget about the syndesmosis, which is a joint itself and ligaments at the same time. And it's in the different levels before the ankle joint. Of course, if you have any patient with problem, you have to take starting from type of things will help you to plan your management. Physical exam is important because you need to know about the neurovascular and any deformity in the problem with the patient. You need to check if there is any skin deformity or skin loss. And also this will help you to plan your management. So for us, after you do history and proper examination, you need also to go for your radiographic evaluation. For usually for ankle, you cannot talk about just ankle, because ankle itself, it's not work alone. Usually ankle work with foot. So both together, we deal with them like one unit. So when you do a radiograph, it should be involving at least a part of the hind foot, not just the ankle joint. So when you do plain films, you need to do AP, lateral, and ankle mortise. And all of us, of course, you know how to read the X-ray about the ankle joint and what exactly you look in each view. But the X-ray usually people forget is the X-ray in the proximal tibia and fibula, because usually there's some fractures and some trauma associated with proximal injury, especially the proximal fibular fracture. Also, why we need to X-ray the foot, because there is a X-ray, there is a fractures usually associated with ankle problem, like fracture of the fifth metatarsal base and calcaneal fracture. Mortise View for us is very important, and you need to know how to do Mortise View and how to read and exactly what are you looking for, and all this are the parameters that you are looking for in the Mortise View X-ray. In the lateral view, you are looking for the posterior malleus, of course. What's the other imaging modalities? We have stress view, which you can do it by gravity or manual. Also, we do CT. CT is important because we can assess the joint involvement if there is any posterior malleolar fracture, and it helps you to plan your surgery. And MRI, it's very important for sport medicine injuries. You need to assess to see if there is any ligaments injury or osteochondral defects. So let's start talking about ankle biomechanics. Ankle is a 3D dimensional joint. It's formed by ankle joint and at the same time foot joints. So as I mentioned, you need to deal with both of them as a one unit. We need to understand that when you are walking, especially in the instant phase, as I explained before, there is a huge weight coming through the ankle joint and foot. And this joint, usually it's about 4 times the body weight. So any deformity or any problem in the ankle joint can lead to disruption of this biomechanics. And for example, if you have any abnormality in the joint, like the talus is not in the place within the median and lateral malleus and within direct contact with the distal tibia, it leads to major distraction and major distribution or wrong distribution of this body weight Like in this example, for 1 millimeter talar shift, you distribute 40% outside the joint. So let's see to this diagram. This diagram is comparing walking and running and the load to the ankle joint. If you can see the vertical forces while you are walking, it's about 120% of the body weight. So this is when you are just walking. But when you are running, it's obviously you put a lot, about double of this. When you are running on through your weight, it's about 275% from your weight. It's transmitting through the ankle joint and foot. 60% of this weight, it's carried by the hind foot. That is why I'm talking not usually about just ankle. You have to combine the foot. So if you have any anatomical problem or ligament problem of the hind foot, this will eventually affect the biomechanics of the ankle joint. And 28% of this amount, of this 120%, or this 75%, it's carried out through the forefoot. So in conclusion, that you need normal ankle, normal hind foot, and normal forefoot to allow us to walk normally or run normally. So what are the normal arrangement of movement of the ankle joint? You need, of course, dorsiflexion, plantar flexion, and you need some kind of medial and lateral valgus and varus, and we will explain this. So this is very tricky because before we understand the biomechanics of the ankle joint, you believe that, or we believe that, the dorsiflexion and plantar flexion is just an movement through one plan. What that means? That means if you see here, we believe that maybe the ankle joint is just going through dorsal flexion, through medial and lateral axis of the ankle joint. But actually, by biomechanics, this theory was wrong, because when you are doing dorsiflexion, it's not just a dorsiflexion, it's also contains some kind of pronation of the foot. So it's combined movement, like dorsiflexion at the level of the ankle joint, and at the same time, there is a pronation in the midfoot. The same idea is here when you are doing plantar flexion. It's not just a simple movement like in the axis of medial and lateral at the ankle joint, no. It also contains some kind of supination movement here at the level of the foot. And this is explained more why we are taking foot and ankle as the same unit, or just one unit. Okay, here also you can see there's some movements that helps to navigate through the ankle joint biomechanic, which is subtalar movement. Again, we cannot take flexion, extension alone of the ankle joint. We have to consider foot, midfoot, and hind foot. In the hind foot, we have inversion and abduction, and also we have inversion and abduction. And I will show you all this movement combined together. It allowed you to stand on uneven surfaces. Okay, so this diagram here explains how much torque or how much isometric torque or maximum effort usually applied through the ankle joint when you are doing this kind of movement. As we explain here, it's not just like dorsiflexion and plantar flexion, it's also combined with foot movements. So let's see here, when you're doing plantar flexion, usually there's torque about 1,000, it reaches up to 1,000 kilograms. And you can imagine how much this is heavy weight on the ankle joint. And when you are doing dorsiflexion while you are walking or running, Also, the amount of the torque or amount of the weight comes through the ankle and foot joint is about 500 kilograms. And the same during inversion and eversion. And يعني متوسط الوزن الطبيعي للإنسان بيكون about 80%, 80 kilos. So you can imagine how much these amounts it comes through the joint. So it's about double or 5 or 6 times the weight of the normal healthy man. So if you have this a lot or this amount, huge amount of weight coming through the ankle joint and hind foot and midfoot, you have to have some kind of stabilizers working in harmony together to transmit this huge weight through normal physiology and normal biomechanics and transmit all this weight safely without breaking or disrupting or doing any kind of ligament rupture to the ground. Here, explain all this combination together. You can see here this man is standing comfortably on uneven surfaces. You can see in this foot is almost neutral at the level of the ankle joint, but at the level of the midfoot, there is a mild supination. And here you can see here some valgus and supination, and at the same time there's some kind of a crease of the medial arch. And even though this man, I'm sure, and all of us will not feel any pain or any discomfort because all these biodynamics of muscle, ligaments, and bone work together in harmony. So let's explain more. We are using now, I don't think this is available like in almost most of the centers, but we use what we call dynamic video barograph. It helps to understand the biomechanics of the foot and ankle. It's like it's called gait cycle analysis. It's a part of the gait cycle analysis. And again, it's all about the gait and walking and running. So how it helps you this? It helps you to allow to see exactly what the kind of the footprint. And I will explain with some examples at the end of this lecture. And it depends on 3 criteria, which is contact area and pressure distribution and center of pressure progression. Here in the right, you can see this is a normal. You can see maximum effort comes through the heels, lateral column of the foot, and metatarsal. And here is the big toe. So when we do the dynamic video barograph, usually it helps to understand if there is any problem in the ankle, any problem in the foot, and it helps to predict where is exactly the point of the problem and what exactly we need to do to have like this perfect, normal, physiological footprint, okay? And because we are looking for this red line, which is called center of progression, center of pressure progression, which is called COP. We need to understand the biomechanics and anatomy of the foot in every case. So again, here's the gait cycle. It usually starts with heel strike, stand phase, and push off and swing this. And you can see here throughout the gait, you can see the ankle joint motion, it varies. Like when you start by heel strike, it's the most common, start with plantar flexion, and then it's progressed to gradual dorsiflexion, and then become severe or massive plantar flexion, and then it comes during the swing phase to neutral position. So to understand biomechanics and relation between the gait cycle, muscle, ligaments, joint, bone, and the footprint. I bring this diagram, and we will divide together the gate to three main components, which is heel rocker, mid-foot rocker, and forefoot rocker. Why all these three steps is important? If we go back here to gate, you can see in all these steps, which is heel strike and mid distance and forefoot, here is the maximum load. In the others, starting from here, there is no load on the foot or ankle joint. So if you have a patient, because we are orthopedic surgeons, it comes to you with abnormality, usually abnormality appear, or the clinical problem appear when the patient is during the distance phase. Like he will feel pain if he is having heel problem, so the heel strike will be a problem. He will have pain or uncomfortable if there is flat foot or any problem in the mid-foot joint, in the mid-distance phase. Also, he will have pain or he will be functionless if he's having any problem here with this start or pre-swing or push-up phase. So to understand the biomechanics of the ankle, you need to concentrate on this area here. So we divide it to three, which is the first locker اللي هي landing response اللي هي انت اول ما تعمل الهيل سترايك. اسمها heel strike. You can see here because the first part of the foot اول حته بتهبش الارض في بدايه المشي اللي هي الهيل strike. So if you have a problem here, let's say like for example a heel fracture, of course the patient will have pain here. So this is the first step here. We call it first rocker. طيب لاحظوا معي هنا في الرسمة دي. لو لاحظتوا في الهيل روكر بيكون عندنا، لاحظ معي الشافت of the tibia and talus and foot all in the same axis. يعني كلها بتتحرك as one unit. يعني بيحصل الهيل سترايك، الشافت of the tibia moves 95 degree and at the same time الفوت نفسها ذاتها بتمشي 95 degree. الزاوية ثابتة في كل الفيرست ستيب دي، يعني هنا ما في أي تغيير في الزاوية. معناها شنو؟ في المرحلة تحت الهيل سترايك لازم يكون التشيك أو المفتاح المثبت الأنكل جوين يكون ثابت لوكت تماما عشان إحنا نقدر نعمل الحركة دي، عشان الرجل كلها تتحرك في as a one unit. Okay, and I will explain later more. نجي للسكند روكر. لو جينا بنفس الفهم وبنفس الفكرة اللي فهمنا بها الفيرست روكر، في السكند روكر لاحظ معي الفوت ما بتتحرك، بتكون ثابتة تماما على الأرض هنا. أوكي، اللي بيتحرك شنو؟ الشافت اوف ذا تيبيا. إذا في المرحلة دي لازم يكون في لوك هنا في الفوت، لكن في شوية flexibility في الأنكل جوينت. So again في الفيرست روكر لازم يكون في لوك في الفوت وفي الأنكل عشان كلها تتحرك as one unit. في السكند روكر بنحتاج إنه يكون في شوية flexibility at the level of the ankle joint، لكن هنا في الفوت لازم تكون completely locked. So here because the movement is only about the shaft of the tibia. يعني لاحظ معي بتحرك من 95 degree ل 80 degree عشان يعمل لك إنه الإنسان يقدر يمشي لقدام. بعدين نجي للثيرد لوكر. لاحظ معي هنا في السكند لوكر الفوت برينت، الفوت completely in total contact with the floor. في الهيل سترايك just the heel in contact with the floor. نجي للخطوة الأخيرة اللي هي شنو؟ اللي هي الثيرد لوكر، اللي هي دي بداية أو بري سوينج فيز. هنا at the same time بيحصل إنه بنكون مواصلين في إنه نمشي لقدام اللي هي التيبيا بتكون ماشيه لقدام بنفس الطريقه about 5 degrees، لكن بيكون في هنا mild lock at the level of the ankle joint، لكن في شويه flexibility هنا at the level of the foot. يعني هنا الاثنين بيكونوا locked، هنا بتكون الفوت locked الانكل فري، هنا بيكون الانكل locked الفور فوت فري. وهنا بنشوف انه الفوت برينت different in any steps. دي بتساعدك بعدين في الفوت اناليسيس او الجيت اناليسيس بتاعتك لما يكون عندك مريض داير تعمل له جيت اناليسيس. طيب نمسك الاولى اللي هي زي ما احنا قلنا الفوت is completely اللي هو الهيل سترايك، بتكون كلهم locked at the same time. نشوف هنا البايوميكانكس في الحته دي كيف بتظبط انه احنا نخلي الرجل كلها الفوت اند انكل locked at the same time، اللي هي اسمها الفيرست لوكر. المشكله في الحاجه دي يا جماعه ان هي دي الحته اللي بيحصل فيها اللودنج كله. يعني انت لما تيجي نازل على الهيل سترايك كل وزنك بيكون transmitted through your heels and ankle to the floor. فبيحصل 3 حاجات. التيبيا بتمشي في internal rotation، الانكل بيمشي في plantar flexion، والفوت بتكون فيها شويه subtalar valgus اللي هي زي ما احنا شايفين هنا بيحصل internal rotation في التيبيا، والانكل بيحصل فيه plantar flexion، والسبتالر بيحصل فيه شويه valgus. طيب لما نيجي نعمل اناليسيس بالجيت لاب، احنا في مرحله هنا اللي هي في المرحله دي اللي هي اول واحده اللي هي احنا بنيجي الهيل سترايك، اوكي، اللي هي دي فيها الماكسيمم لودنج ريسبونس وفيها الشوك ابزوربر. فهنا في الحته دي اذا احنا قارنا الدورس فليكشن مع البلانتر فليكشن احنا بقى اولموست نيوترال، لانه زي ما قلنا احنا لازم تكون الاثنين لوكت الانكل والفوت عشان يتحركوا كلهم از وان يونت. طيب نيجي للسكند لوكر اللي هي انه بتكون الفوت لوكت completely in total contact with the floor، لكن بتتحرك شنو؟ التيبيا زي ما احنا شايفين هنا في الراجل ده هنا، اوكي، اللي هي دي ميد ديستانس. برضه بيكون فيها اللوت لانه انت هنا بتبدا ترفع رجلك الثانيه وكل الويت بيبدا بعد ده completely بيحصل شنو؟ distribution through the left foot and ankle to the floor. طيب اللي بيحصل شنو هنا؟ بيحصل انه اول حاجه عكس هناك كان بيحصل internal rotation في التيبي، هنا بيحصل external rotation. الانكل بيمشي في dorsiflexion والسبتيلر بيحصل فيه inversion and abduction. طيب هنا في الجيت اناليسيس بنشوف احنا في موقع هنا في النص بدينا نتحرك، هنا احنا كنا نيوترال، هنا في more dorsiflexion in the second rocker. نجي للثيرد روكر. الثيرد روكر قلنا نرجع للمرحله الاولى اللي هي الفيرست لوكر، بيكون الانكل لوكت، الهايند فوت لوكت، لكن بيحصل هنا شويه فلكسبيليتي في الفور فوت. في الفوت برينت بيكون كل الويت ترانسميتد ثرو ذا ميتاتارسل. يعني احنا اذا عندنا واحد عنده fractures في الميتاتارسل هيدز he cannot apply this movement، اوكي، اللي هي زي ما شايفينها احنا هنا، اللي هي دي بيحصل فيها شنو؟ برضه بيحصل فيها external rotation، بيحصل فيها dorsiflexion and subtalar varus and adduction which is very similar to the second rocker. لكن في المرحلة دي احنا بنيجي هنا بنيجي ماشيين على شوية more dorsiflexion. طيب الثيرد روكر لما عملوا compare اللي هو في المرحلة الثالثة اللي هي فيها البوش اوف دي، لقوا انه فيها الماكسيمم انكل مومنت اند انكل باور. يعني شنو الكلام ده؟ معناه انه لما جو عملوا اناليسيس للباور والتندونس وكل الويت اللي ابلايد على الانكل والهايند فوت جوينت في الستبس اللي احنا شرحناها دي، لقوا انه في السيرد اللي هي اخر واحده منها وانت بتعمل بوش اوف اللي هي بتحمل فيها على الفور فوت، لقوا انه البلانتر فليكشن بيكون at the maximum والانكل باور بتكون at the maximum. اوكي، اذا بالنسبه لنا اذا انت داير تفهم الحته دي، الماكسيمم باور في الماسل والليجمنتس والويت كله بيكون في الثيرد روكر ده. طيب هنا عندنا some clinical examples اللي هي like this first one is this equinus, and here we have this calcaneus and equinovirus and caves. طيب احنا هسي قدرنا نفهم الفكره بتاعت علاقه الانكل مع الهايند فوت مع الجيت. اذا عندنا اي disruption، عرفنا النورمال، اذا عندنا اي disruption في الاناتومي، سواء كان الاناتومي ده from the bone deformity or ligament deformity, it will affect the gait and it will affect the biomechanics of the ankle and foot. And here's some examples. طيب خلينا نربط الحياة دي كلها مع بعض ونخطها in clinical practice example. طيب العيان ده عنده equinus، نتخيل انه عيان equinus، جاتك الجيت اناليسيس بتاعته، الفوت برنت جاتك بالشكل ده. اذا احنا هنا اذا لاحظنا انه الماكسيمم كله قاعد وين؟ في الفور فوت، في الميتاتارسلز. اذا معناها العيان ده عنده مشكله انه ما قادر يخد رجله على الواطه بصوره طبيعيه، معناها احنا نتخيل انه المشكله في الفوت and the ankle، معناها انه الانكل فيه some sort of equinus عنده plantar flexion، ما قادر يعمل complete touch او ما قادر يدينا full finger print على الفوت برنت. ده مثال لها. طيب نشوف المثال بتاعها اللي احنا هسي شفناها دي. بنشوف العام يمشي كيف. Okay, if you can see here, the problem is the ankle. It's completely in equinus, complete plantar flexion, and the forefoot. You can see there is varus deformity also. And if you can compare this walk with the previous slide, it's completely typical. Okay, so that is why when you need to analyze any ankle or foot biomechanic deformity, you need to know how to use a footprint. طيب نمشي للإكزامبل اللي بعديها. برضو احنا عندنا هنا قبل زي ما شرحنا الفوت برينتس لازم يكون عندك heel, lateral column, metatarsals وبيج تو. لكن لاحظ معي هنا في مشكلة انه ما عندنا medial arch emptiness، يعني يديك احساس انه الرجل دي كلها completely in touch with the floor. That is mean انه هنا لما احنا نعاينها انه في valgus problem in this foot. Okay, and eventually معناها عندنا برضه valgus problem in the ankle joint. طيب نشوف example now. شايف يعني لاحظ الرجل اليمين is okay، لكن لاحظ الرجل الشمال is in complete contact with the floor. اوكي يعني زي البطه، ما في اي ارش ميديالي، فالعيان بيكون ضاغط برجله كلها على الرجل. فاحنا هنا لما نشوف الفوت برين دي طوال احنا we put in our mind اوكي العيان ده عنده most probably عنده valgus ankle and at the same time عنده some kind of flat feet or complete valgus deformity of the foot. طيب let's see the last example. هنا الماكسيمم at the heel, here completely absent everything. شايفين الزول اللي عمل لنا العمل الفوت برنت مسح كل ده، قال يا اخي انه لا ما في اي تاتش هنا. فهنا العيان كل البريشر applied through the heel. And here is the example. هنا العيان بيكون ماشي completely بشنو بالهيلز بتاعته. فهنا بتلاحظ انه there is a complete disruption of the biomechanics. You can see there is the ankle is in complete maximum dorsiflexion and the foot cannot touch the floor. طيب so for all these cases and for the basics of biomechanics of the ankle, you need to understand just one thing. إنه الأنكل joint والhind foot والmid foot and forefoot joint كلها بتشتغل in harmony together بالإضافة مع المصل والليجامنتس. ليه؟ الهدف في النهاية إنه إحنا ربنا لما خلق الناس خلقهم بحيث إنه لما يجي ماشي يمشي بصورة comfortable، يمشي بطريقة صحيحة، ما يحس بأي ألم. طيب عشان يحصل الحاجة دي لازم يكون الويت transmitted through all the joints. زي ما احنا عارفين احنا عندنا حاجة اسمها الميكانيكال اكسس والاناتوميكال اكسس، لازم تكون ماشية كلها in harmony. فلما ناخد ال long axis of the weight in the lateral side في الانكل جوينت بنلقى انه عشان انت الويت ده يمشي بصورة proper transmitted without causing any pain or any harm or damage to any structure, it should be anterior للpoint A اللي هي شنو؟ اللي هي الجنكشن between التيبيا and talus اللي هي بسموها talocrural joint أو الأنكل joint. ولازم يكون posterior للميتاتارسوفارنجيال joint. في الحتة دي في النص تماما الويت can be transmitted safely. ولما العيان ده نفسه يخط رجله على الأرض نفس القصة، لازم يكون الويت ماشي in the same direction، لازم يكون in the middle exactly. أنا اديتكم مثال بالcomplicated example ده لأنه لازم تعرف إنه gastrocnemius ligaments muscle joints all work together in harmony عشان تخلي لي axis of the weight يكون دائما and always between point A and point B. اوكي عشان البودي ويت يمشي straight to the ground without causing any damage. ودي حاجه هنا بيشبهوها بالليفر ارم لما تيجي تشيل اللي هي اللي احنا بنسميها الدرداله في السودان. ف لو ما اتعملت بالطريقه دي هنا المصل اللي هي الجاستروكليمياس واللود اللي هو الويت اوف ذا بودي والاكسس اللي هو الميتاتارسوفارنجيال اللي هو ده لانه هو ده اخر joint touch the floor when you are starting to do pre-swing in the gait analysis. I understand انه البايوميكانكس it's difficult to be understand لكن انا I tried انه اخدها لكم بصوره simple بحيث انكم تقدروا تفهموا main idea about ankle biomechanics. حقيقة my recommendation is to read this textbook. الكتاب ده is very very helpful in understanding the biomechanics of all the body. أنا استفدت منه جدا. ده من الكتب اللي أنا بنصح بها بشدة إنه الناس تحاول تذاكر منها. أنا I will share it مع دكتور بحاري عشان to be shared in the Telegram group إن شاء الله. So thank you and the floor now is open for questions.
Thank you, Dr. Shareef.
I recommend it. اللي هو كتاب حقيقة الواحد يكتشفه متأخر جدا اللي هو ده اللي هو الكتاب ده اللي هو Kinesiology of Musculoskeletal System. الكتاب ده هو الناس بتفتكر إنه هو حقيقة كتاب بتاع just physiotherapist لأنه بيقولوا foundation for rehab